And as a point of reference, I would like to share a little bit about Telliant Systems. We are a 2020 Inc. 5000 list member, and we are celebrating our 10th anniversary this year in business. We are based in Alpharetta, Georgia, and we are a custom software development and testing services firm. We are excited about AI and new technologies and the possibilities of integrating them into our clients' new and existing software applications. Please let us know if we can help you with anything. At this time, somebody's going to turn on the recording, which is great. At this time, I'd like to introduce Seth Narayanan, founder and CEO of Telliant Systems, a serial entrepreneur that he is in software and technology, and a digital health board member for the Technology Association of Georgia. Seth?
Hey, thanks a lot, Tracy. Can you all hear me?
Yes.
Okay, great.
Yes.
Excellent. Like Tracy said, we are very excited today to launch our Digital Currents Conversation Series with our first conversation today about the use of artificial intelligence in the clinical areas of healthcare. There are so many applications in AI in healthcare, and our guest today, Shantanu Nigam, is one of the pioneers in that space, and so we are very excited to have him join us today. Shantanu is a veteran entrepreneur and is a founding CEO of a company called Javion. Javion, which is based here in Atlanta, was founded in 2010, and after close to 10 years in 2019, Shantanu has transitioned and is now serving on the board, collaborating with the executive leadership team to influence Javion's direction as the organization continues to its next stage of growth. Shantanu has earned his Bachelor of Engineering degree from the Indian Institute of Technology, which is one of the top institutes of learning in India. Javion has created a state-of-the-art AI platform for prescriptive analytics for preventable harm with an aim to improve patient outcomes using its clinical AI platform. Javion has won several awards for innovation and for predictive analytics work that they have done. Shantanu's career path started in the late 90s when he founded an AI company that was shifting search algorithms from keyword-based to intent-driven solutions through the use of eigenspace. Shantanu moved then into Accenture's healthcare practice, where he served in a leadership position for the most of the 2000s. And in addition to leading multiple payer and provider consulting engagements, Shantanu helped bring to market some of Accenture's most innovative and leading edge offerings. Shantanu has a passion for artificial intelligence in general and inpatient wellness specifically. His drive is fueled by a unique background that spans healthcare and transforming AI technology for over 20 years, which has changed the way complex problems are understood and solved in this industry. So we are very excited to have Shantanu join us and talk to us today about AI and healthcare, especially in the clinical space. So with that, I would like to welcome Shantanu. Shantanu, thanks for joining us. We greatly appreciate having you join us today.
Thank you, Seth. These kind of introductions make you feel so much smarter than you are. Let me share my screen.
And he scales tall buildings in a single bound.
Hey, well, if the shoe fits, you got to wear it, right?
Can you all see my screen?
Yes.
Okay, awesome. So thank you folks for joining. It's a short presentation, I promise you, it's not very long. I'm gonna start with
You're muted.
Can you hear me?
Yeah.
Okay, awesome. So technical glitch. Just bear with me for a minute. This is something you all already know, but I'm going to just spend a few seconds on this data point. So we know our spend is very high in healthcare. To get a perspective, if you compare our spend as a percentage of GDP against all developed nations, we can see we are close to 18% of our GDP, which is about almost double the average of all developed countries, and certainly the highest among them. So we spend a lot on healthcare. Okay, great. And if you look at what does it translate to in terms of results, there are tons of metrics to measure how good or bad healthcare overall is in a country. But these are some of the metrics that are very easily considered by most world organizations as an indicator. So looking at heart conditions, 8 standard 30-day mortality across AMI, acute myocardial infarction, ischemic stroke, or hemorrhagic stroke. We can see we are about the same as the average of other developed nations. A little lower on ischemic stroke, but a little better on hemorrhagic stroke. So we are performing as well as other developed nations on some of these metrics. The most relevant metric to assess healthcare in a large geography by WHO and a lot of other similar organizations is amenable mortality. What that means is mortality, people dying of preventable diseases. So generally, if more people are dying of preventable diseases, then you could have stopped those fatalities and you were not able to. If you look at this rating, according to HAQ rating, we are worst among all the developed nations. And they're far away from the average. And there's nothing to be proud of on this slide. The lower numbers, just to clarify, lower numbers indicate bad performance. It doesn't indicate less mortality. In fact, indicates higher mortality according to HAQ rating. So we spend a lot more than all the developed nations, but our healthcare is either at par on certain metrics, about average, or it's bad. It's probably at the bottom on a lot of other metrics. Why does that happen? It simply happens because about 1/3 of our healthcare spend contributes to waste. Waste meaning it's not helping patient outcomes. It's either going to a financial waste where dollars spent are not driving positive outcomes, or it's things being done to patients that are not helping the individual outcomes. So clinical and financial waste. 1/3 of our healthcare contributing to waste, just to understand the magnitude of that, that's about 6% of our GDP. A big problem, a lot of waste, billions and trillions of dollars, and most of it avoidable. So that makes it a classic case for AI. If you knew it happened, if you knew it was going to happen before it happened, you could stop it in theory. That's predictive analytics for you. That's the way predictive analytics or AI works in every other industry. Same here, except there are certain things that haven't worked out very well when we've tried to apply predictive analytics and AI in healthcare, particularly on the clinical side. And let's understand that a little bit more. If you go back to CMS definition of what avoidable harm / synonymous with avoidable clinical waste is, CMS defines it as identifiable and modifiable. Let's understand these terms a little bit more. If it's identifiable, if you knew it was going to happen before it happened, if a patient was going to have acute myocardial infarction and you knew 2 months before that the patient had a higher risk of having that, if a patient was going to have some kind of sepsis or pressure injury stage 3 and 4, which could be fatal, and you knew before it happened, then that's identifiable. But they also include another word, modifiable. In addition to being identifiable, modifiable is equally, if not more important, which means not just that you should know before it happened, it should be modifiable. There are a lot of situations where just knowing is not enough because you cannot change the outcome. You know you were right. Yes, I called it out. I was right. But can you really do anything about it? In some cases, you cannot. And in those cases, the path of care, the care pathway, is very different than the cases where you can actually do something about it. And if you do not understand the difference between modifiable and non-modifiable, then we provide bad care to patients. Like we won't put them into end-of-life care when they should be getting into end-of-life care. They'll keep on going through more and more cutting and going into the patient, which is not the right way, not the dignified way of patients as they reach the end of life. There'll be wastage of dollars, wastage of resources. We saw these situations happen with COVID. Putting every patient on a ventilator was not the right thing. You got to be selective when you are short on ventilators. New York, we saw it happen in so many instances. But the point here is when we look at AI to be applied to solving this problem, identifiable is as important as modifiable is as important as identifiable. In fact, I would argue it's even more important because just knowing without being able to make a change is kind of just an academic exercise. However, today, most companies, even hospital systems that are considered to be good educational hospital systems, are only focused on identifiable while they're completely ignoring modifiable aspect of the solution. And I'll tell you why this is happening. It's happening because predictive analytics or AI in every other industry only focuses on identifiable. Amazon is only concerned about what you're going to buy. What is the highest chance of you going to buy in the next week? Target is only concerned about which aisle you probably go, so I could position which product there. In sports, betting, you're concerned about what are the odds of a game. In healthcare, when it's about patients, it completely flips. People do not recognize it. In healthcare, if we keep our focus on identifiable, we keep finding risk on patients. Yes, there's the risk. Let's improve the risk propensity. 70%, 80%, 90%, 95% of finding risk on a sepsis patient while completely ignoring the modifiable aspect. That's how things are happening today. And that is precisely why the waste is still where it is and avoidable harm is where it is, and it hasn't been solved. Let me talk a little bit more about this as a real world example of what happens when these systems try to apply technology without understanding that key aspect of clinical nature of patients. So here's how most of these systems work today. You'd build a neural network or some kind of regression machine, and the machine will be motivated to finding the product will find a problem. Let's say it's sepsis. You got to reduce sepsis. It's avoidable in most cases, not in all cases. So you're going to reduce sepsis. So let's build a model, build a neural network driven model. The model is motivated to putting all the right answers at the top. It's going to stack rank all the patients. Highest risk patient at the top, lowest risk at the bottom. Then take a slice from the top, give it to a nurse and say, nurse, work the slice. This is the highest list of highest risk patients. Sounds good, except what happens is when the nurses get that list, if your system is only motivated to finding the right answers at the top, the answers will be right. Those will be patients who will probably have sepsis. But when your machine is so focused on getting the right answer at the top, you will get patients that the nurse will see and nurse will say, you know what, you are right. That patient will have sepsis. That 87-year-old patient with 3 comorbidities is at high risk of sepsis. I could look in the eye of that patient and tell you that patient will have pressure injury or a fall or sepsis. What did you tell me? Nothing very exciting. You're giving me obvious patients. And second, so what? You told me that patient is going to have something. So what? The nurse's workflow doesn't change. They still have to follow the same workflow because nothing's going to change. That patient will still have that bad deterioration. And even more than that, when the machine keeps alarming beep, beep, beep on a patient and the nurse knows that you're not telling them anything they don't know, these are the obvious patients that are even unmodifiable, it just adds to alarm fatigue. And very quickly, the insight becomes alarm fatigue. And once they start to look at this as alarm fatigue, they start ignoring it. And even the ones that are forced to not ignore it, we can train them and train them and train them. They look at this and still say, well, fine, maybe you are right. This is not an obvious patient. Maybe this is a modifiable patient. This 35-year-old person, athlete, who had, because this person had some substance abuse history, Now that person is on a risk of dementia or suicide. Maybe we can do something with this. But until we change their workflow, it's still unactionable. Until we provide which intervention should be applied as opposed to what they would normally do in their normal day, it's still not actionable. So they would appreciate the insight, still nothing happens. This is the part that most of the industry today is missing out. And I've been in person in front of large systems that we work with together with, systems like Intermountain Healthcare, Geisinger, Duke, Cleveland Clinic, Mayo, MD Anderson. We've been in there in those systems and seen so many programs missing this out until we got in and were able to move the needle a little bit more on the ground. The bottom line in all of this is, I think all of this slide might look a little complicated. There are all these things happening on this, but the bottom line is the systems, until the right technology that is focused on the root cause of the problem finds the identifiable patients as well as modifiability on the patients, it's not going to move the needle. It's only going to be an academic exercise. And a big disservice that keeps on happening along with this is when we write papers, if you look at New England Journal of Medicine, there are tons of papers that are only talking about positive predictive value and their sensitivity and specificity, which is only historically going back into, are you identifying the patients correctly or not, with absolutely no mention of modifiability. That doesn't really help the industry too much. So the point here is, I think we have to be aware that there's a clinical AI is very different than supply chain AI or weather AI or sports AI. In clinical AI, modifiability is extremely important because the patients will not realize the benefit of AI. It will stay an academic exercise. I'm going to switch to a case study here and just show a real world example of when you apply something like this, what can happen. This is a small system, and by design, it's easier to show this kind of value in a in Trinity system or Intermountain or those kind of large systems that have a lot of infrastructure. But this is a small system in Alabama, Montgomery, the Baptist system. It's not quite in the middle of nowhere, but it's not in New York. It's less. They are challenged on resources. They are challenged on a lot of things, even finding good skills. Even at this system, let me give you a 15-second background on the system. They were managing their employee population themselves. And that was about just 2,500 employees, not a big population. And even in that smaller population, we applied some of the vectors where we anticipated certain types of risk on patients, and found the cost brackets of which patients are going to be deteriorating the most. And they found interventions along with the program to reach out to those patients. There were only 3 nurses involved in this program, and the cost of managing 2,500 employees and their families went from $9.5 million to $4.5 million. This is the claims cost, so the actual cost is a component of that, but you get an idea. It's almost in half. And when you go back into doing the gross versus net, you find out there's almost a 30% reduction in managing that cost. This also translated to, if we look at just the top 100 costliest patients, costliest is synonymous with patients that had the most deterioration. The cost was reduced by about $3 million in just 1 year. And this is a system that is not positioned to use AI perfectly. This is a system that doesn't have all the bells and whistles and the tools. It's in Montgomery, not sitting in some very privileged place. I'm going to take a pause, just do a time check here, Seth. Can we do another case study or should we switch to questions? Seth, you're on mute.
Thank you. Sorry about that. Yes, Shantanu, we still have quite a bit of time left. So yeah, feel free to talk about another case study. That would be very helpful.
Okay. All right. Perfect. I'm going to spend, maybe if we have enough time, just maybe a minute more on this slide across a few other dimensions.
Absolutely.
at this system, we had the employee population impact. Along with that, we looked at avoidable waste along ER visits, the ER visits that were not needed. ER is it's actually for emergencies, but as we all know, a lot of times this ends up somebody had 101 fever and they coughed, and now you're suddenly sitting in ER, adding to the costs of the system as well as taking away from what that system, what ER should be attending to. We were able to reduce ER visits by about 245 by identifying which patients are likely and which patients are more likely to understand and change their behavior, as well as which are likely to go and jump into ER in the next 30-45 days, as well as inpatient admissions were reduced drastically. Now, this reduction of 377 inpatient visits, unfortunately, our healthcare is where it is. This was a great metric, except it didn't help the system financially too much because it took away a little bit of their revenue. It's the right thing to do. It's the ethical thing to do. So the system did it. We are very proud to be partnering with the system. But the way that our healthcare is, these kind of metrics help the patient outcomes. Less IP visit means some patients who were going to be admitted were not going to be admitted. They had, in fact, outpatient procedure, or they had something else administered to them, which helped them not have to sit in the hospital. This is one example, but these 3-4 metrics around this example are expandable to a lot of systems. And I've personally seen more than 50 systems that have benefited across some variation of these kind of metrics by simply applying AI that is aware of identifiability as well as modifiability. We look at one other example here. This one is a slightly larger system, Unity Point Health. They have 20 some sites. And on this system, some very different type of problems were being addressed. One of the problem was COPD admissions. COPD admission is people getting admitted because of COPD exacerbation or COPD deterioration. And this is considered largely to be avoidable, because if you provide the right kind of care and attention, this should not happen in most patients. These are usually patients who haven't really quit smoking as they were advised to, or their lifestyle is driving these kind of things. This number was reduced by almost half at one of the pilot clinics where we were able to go back and measure these numbers. Along with that, there were about close to a little less than $1 million of avoided costs reduced on inpatient admissions by applying exactly the same kind of methodology and solution to these patients. In this system, the avoided IP admission translated directly into cost because they had risk on these patients. However, there are a lot of hospital systems where they do not take risk. In those cases, it wouldn't translate to dollars. I'm gonna take a pause on this one. I think Seth, that's about all the case study and the presentation. Do we switch to questions, or do you have any questions?
Yeah, there are questions. The audience has asked some questions, and I also have some questions that we have prepared earlier. So we'll mix it up here. Why don't I get started with a couple of the questions that have been posed by audience members here. Michael was asking, we are talking about neural network, correct? I'm not sure exactly at which point he asked that question, but maybe you can answer.
Right at the beginning.
At the beginning, okay.
Yeah,
yeah.
Sure. So the question was, if I understand it correctly, you want me to elaborate on application of neural network to these kind of problems?
Exactly. Years ago, we did some work at HBO with neural nets and had some issues. So I realized that the technology's come a long way. So a description of how that works today in today's world would be very, very helpful.
Yeah, sure. Let me pick up an example. So, for example, if a system has has pressure injury stage 3 and 4 as a problem they want to reduce. What that means is patients who are coming into the hospital without pressure injury as initial diagnosis end up getting pressure injury while they are staying in the beds because of wetness and lack of movement or whatever that be. That's an avoidable condition. And if you want to apply AI to that problem, the way typically you would go about it is you would pick up historical data and say, what is the propensity of developing pressure injury? The factors are mobility, hygiene, the type of medication the patient is on, and so on and so forth. And you would build a model based on historical data. And then as new patients come in, you would start to find out what is the propensity of each patient. Neural networks work really well for that situation. And you would try to make the neural network learn from past historical data and try to predict for a new patient. Shantanu gets into the hospital, Shantanu is lazy, and so on. So he has a higher chance of developing pressure injury stage 3 and 4. So I get a flag on Shantanu. But the problem I talked about, modifiability, neural network-based systems in today's day and age. I don't know, Michael, what year you were doing that with HBO, but in today's day and age, it's very easy to spin off a neural network. You can go to Google and get some libraries and spin it off very easily. The problem is neural networks are forward-looking. So they will tell you what can happen to the patient. They will focus on the identifiable aspect. They will not be able to tell you the modifiability. And there's a very structured, there's a problem in the way they are structured. They go by layer by layer by layer by layer. So information goes from one layer at the start to other layers. And as information goes from one layer to the other layer, information gets lost. You cannot, by design, it's very hard for a neural network to go back and say, had I changed the medication or something else, would that change the outcome? Or which intervention would actually change the outcome? Or if a patient is even modifiable or not. So that's the shortcoming that neural networks, along with other linear regression techniques in today's AI, other common techniques like random forest and a lot of other techniques, they all exhibit same kind of shortcoming when we try to look at modifiability of patients. Does that help answer the question, Michael?
It does, and again, we've come a long way since we did that experiment many years ago. So I was very much interested in, you know, how far the technology has come. And obviously there's still some holes there, but we're a heck of a lot further along than we were when I did it years ago.
Great. Thank you.
Okay. I think we still have quite a bit of time, so I'm going to take one more question from the attendee here. R. Sinha asks, hey Shantanu, is it because the number of data points showing impactable patients in the training data are too low to train a system? I don't know if that question makes sense.
I think I get the question.
Okay.
So, and the person was R. Sinha, you said?
Yeah, R. Sinha.
Yeah. So R. Sinha, good question. That could be one of the reasons why it's hard to model modifiability. But the bigger problem is lack of awareness. I mean, you would go down to the point of understanding and saying, well, the data points are less, there are more. But for the most part, I've seen systems and companies, not just on the East Coast, this side, on the West Coast, very advanced companies with a lot of money raised and a lot of high-flying people in the companies. The awareness to even look for modifiability is not there. Now, assuming that is there, I think lack of impactable data points in your training set is probably not, I wouldn't focus on that to be the problem. That's something that could be collected if you have the right, if you're gathering the right data. The problem is out-of-the-box solutions will not be able to work very well with that. You would probably need to do something. Now, what we did was we did this eigenspace clustering techniques, but you could do many different techniques. The technique that needs to be done is something that finds out which interventions will work or will not work, and trying to tie it back to will it change the outcome or not. If we completely become agnostic to intervention effectiveness and interventions, we will always keep our focus only on identifiability while completely losing sight of modifiability? A very good question.
Okay. Thanks, Arsena. Thanks, Shantanu. So I'm going to step back a little bit, Shantanu, and maybe for the benefit of everybody here, I think we would like to know, you are an early pioneer in healthcare AI. So could you kind of give us a little bit of background on how you got started in the field of AI and healthcare in the first place?
Yeah, sure. So let me answer this question by giving the root cause of the problem that we started to solve. So last 30, 40 years, the financial levers have not been correctly aligned for the providers. And I'll tell you what I mean by that. What I mean is providers have always been incentivized to do, they are paid for what they do, not for the outcome that the patients have. So for example, a provider does 3 surgeries on a patient, they will get paid 3 times. If one surgery was done, let's say right, and the patient didn't have to come back for second and third surgery, they would be paid a third of the amount, which is completely counterintuitive and opposite to what should be done. We are not here to talk about policies and change, and I'm nobody to even comment on those kind of things, but the reality is that exists. However, in 2010, April 2010, with ACA, we started to see some of the mandates. Now ACA had 20,000 things in there, but a few of the little things in ACA were around mandates that were driving hospital-acquired conditions and hospital-acquired infections. So they were incentivizing providers for better care of the patients, and they were penalizing providers who would have too much of unneeded care when it didn't translate to patient outcome. So that was the trigger where you saw for the first time that the financial levers had a possibility of getting aligned better in our country. So that was the trigger. Combine that trigger with the fact that the problem is huge, and if you could make an impact on this size of a problem, AI is a perfect use case for these kind of problems, because you're talking about proactive, preventative medicine, proactive actions, knowing something that the human brain cannot fathom. You're trying to anticipate things. So AI is a classic use case for that. So that was the idea, to combine these two things. And because the problem is not just huge financially, it's also a problem that takes away lives and causes a lot of harm to patients. So it's a problem that's huge, both in terms of financial as well as ethical human aspect. Combined all those things and found that you could, the world may be changing to a point where those financial levers would be better aligned. So there's a chance for a solution like this that could actually go in and have an opportunity to improve patient outcomes as well as related associated financial waste. That was the trigger, and that's how we got started with this. I had some background in AI in late 90s. Worked with some of the early Google founders. So I had I was privileged to be in a place where I got exposed to certain techniques and things that could go well beyond a lot of easier regression kind of techniques.
Great. Prior to Javion, you had already started using AI in your previous venture. Can you talk a little bit about that and how you came up with the idea for Javion from that?
Yeah, it's a long story and it'll get very quickly boring, so I'll keep it short. I did a startup that failed in '99, and around that time, search, for those of you who are old enough would know, search was, the leaders were AOL, Alta Vista, and so on, and Ask Jeeves. There was no Google, so around that time, late 90s, these search engines, the way they worked was they would look at your keywords. So if you are looking for let's say King James, you're searching for King James, they would find all the documents that have King and James as keyword and get you back all the documents with King James. I came up with a technique using eigenspace to not find keyword-based, go away from keyword-based search to intent-driven search. What that means is when you look for King James, when you search for King James, the machine should come back with medieval history, not King and James. That was pretty good and cutting edge. And I realized later Google applied some similar things, but that was my exposure to AI way back. The company failed, bubble burst, and my VC went bankrupt. So long story short, it failed. But knowing that you could do things like that, knowing that you could cluster things in a way where you know the directional sense of where someone will go. We applied similar technique, similar eigenspace technique on patients and found that you could actually figure out with those techniques that the direction of deterioration of the patient could be changed by which features, which really translates to interventions. So that was the culmination or combining some of the AI that I had been exposed to, I was lucky to be exposed to, and the problem we were trying to solve in healthcare around 2010-11 timeframe.
Very interesting. Okay. I think, where do you see in today's world where healthcare AI is, apart from where Javion solutions are fitting into it? Do you feel like AI has made a sufficient impact already? So can you talk a little bit about maybe what your competitors were doing and where you are or your company was, Javion was in respect to that? So can you talk a little bit about that?
Yeah, it's a complex question. A lot of dimensions to it. Let me start with the human physiology is very complex, and often by the time symptoms start showing up, deterioration has already happened. And current AI is a lot of current AI in the industry is point-based. It's disease specific. It's a model for sepsis. It's a model for acute myocardial infarction. It's a model for something else. I think where AI can go, or where it's reached so far, there are a lot of positive things have happened in the last 4 or 5 years. People have become more open to applying techniques. We are hearing less and less of doctors saying, "Who are you to tell me? I've been doing this for 30 years." As a data point, I'm not involved in the day-to-day at Javion right now for the last about a year or so since since the company got acquired by JMI. But when I was about a year back, we used to track how much of an hour of a sales meeting you're doing to educate people on AI. And we realized that number went down from about 35, 40 minutes in 2016-15 to about barely 5 to 10 minutes. And so there was less of pushback on, is it going to work? And that is the first step, to accept it. Accept that we accept AI. Every time we use our iPhones, there's some AI happening on it. It's you say, Siri, do something, there's some AI happening on it. You look at weather, you're totally trusting AI. You're looking at Google Maps, you're trusting AI. But we do not trust it as much for our own bodies and patients. So that shift has started. We've seen a lot of that shift happen in the last 3-4 years because we are not educating anybody in those meetings. People know what they want, how they apply. However, the belief, I think, in the clinicians is it's not quite where it should be. There's still a lot of skepticism. And unfortunately, when a nurse looks at patients and she sees 7 patients that were right and 1 wrong answer, their belief goes down a little bit, because while the financial incentives were never aligned, our clinicians were ethically always aligned, and they always are. That's why they are in this profession. So they look at that and they start to lack, their trust goes down. Is this system going to kill my patient? Should I do my own thing? And eventually, when they keep on doing their own thing and not listen to the system is worthless. So that one problem of belief is still lacking a little bit. And when solutions that are not well vetted out, when people do not spend too much time trying to test it in a controlled setting and take it to the market because you have pressure from VC to take it quickly to the market and make some money out of it, then that every time a bad system like that comes out, the belief goes down. And once the belief starts to go down in nurses, they start talking about things like clinical AI doesn't work. We had a great, I mean, when we started off in around 2013, we had the best performing models out there, and they failed on the ground. They failed because they were not able to build that trust, because we also ignored some of the aspects of modifiability as well as the sensitivity of nurses. And you're flagging patients with a red and a green button. Both are bad. Green is bad because you don't want to ignore those patients. So I think it's a very complex question, and there are many dimensions to answering that question. But these are some of the dimensions that are, I think, challenges. But that being said, there's leaps and bounds of progress that has been made in the last 3-4 years. And as the quality of solutions that come out in the market improves, I think this will continue to become better because the financial levers are getting aligned better and better. So the drivers are there.
Excellent.
Might I ask, what do you think that the advent of consumerism within healthcare is going to do to that market? Because obviously the culture is changing and we see it happening all the time. But when you start to throw an active consumer into the mix, how do you think that changes the dynamic on the cultural side within the healthcare delivery network?
Oh, I think that should change drastically. The patient behavior, if you tell a patient you are at 85% risk of developing dementia or something, or any kind of problem, there's a very high chance their behavior starts to change. But if the patient is in control, if they are in control and they're making their own decisions, and that comes with consumerism. If in today's world, I can see in my family, people go there, the doctor told them to do something, they'll just do it. They don't even know the care pathway they are on. They're just following a schedule, and which is perfectly fine. They're not supposed to know all of those things. But with consumerism, as patients are enabled to make decisions, it will challenge the caregivers as well. If caregivers, for example, if caregivers had an ability, as a patient, I would question my caregiver and ask them, if you had an ability to running a test on me and knowing if I'm going to develop certain type of nosocomial infection or not, and you did not run that test and just let me go through the care without developing that test, I'm going to question them, and I should be questioning them. In today's world, none of those things come out and even are on the surface. But as we see more and more of consumerism, these kind of questions should come. Decisions, if they're empowered to take decisions, they will eventually take the right decision, which will drive the right behavior on the care providers as well.
Thanks. Thanks, Shantanu. One more quick question from April with Total Dental. Question is, I think she means Javion, have you applied this AI technology that you have outside of a medical space, maybe in dental or chiropractic or some of the other areas? Has there been interest?
There's been a lot of, it's a question you ask yourself every quarter, every year, but the balance is keeping the focus or trying to run after every shiny object. Now, that being said, we've applied it to oncology, and we have a few places where there were some remarkable results in oncology, but not to dental. We've applied it to to preterm birth and certain diseases associated with that. Not so much to dental or other things.
Let me press you on that a little bit. I know that you may not have had the opportunity to do it or had the time to do it, but do you see it applying in those industries from a pure technology and solution point of view?
I think in theory, yes, absolutely, yes. I do not know enough about particularly dental industry to comment about the behavioral aspects of the nurses and their users to know what kind of challenges will be there. But I think in theory, absolutely, yes.
Okay.
There was actually one before that about, can you give us a little bit of extra background on the experience with oncology?
Sure. I'll share one example at one of the oncology practices. This the solution we had applied there was finding 20, I think it was 20 or 30-day mortality and deterioration on patients. And the idea was, if you know that your care pathway could change, you can put them on end-of-life care, or you don't want them to suffer the last few days of their life. That was the high-level use case being applied at this system. This doctor, I think it was Tenank system. This doctor was on a flight, and one of her patient, she got this email. She was checking her email on the flight, and she found this flag that the system had marked one of her patients very as will likely die in the next few days. I mean, in better words, the system won't say it like that, but. So the doctor calls up her nurse practitioner or sends an email to her to look out for this patient. She said this was definitely a wrong flag, and it's probably just the system being a system man flagging it incorrectly. But nevertheless, she said, you know what, check on Ruth, and I'm making up the name, check up on Ruth. She is doing fine. She was here last week, but the system has flagged her. They went back and checked, and her sugar levels were going in a very different direction than expected. And they brought her in, they started checking. She would have been dead in 20 days had they not brought her in that evening. If it was delayed by 24 hours, she would most likely have been dead. But she was given the right care, and it's a story that got published as well. But those are, there are numerous examples like that that just make your heart melt and make you feel proud and good of the work you've done. Financially, there's not as much an incentive on the oncology space because the payment models are not quite in a place where they are aligned to other models, though MACRA and MIPS is trying to get to that point. But I think from a people and ethical standpoint, there are tons of stories like that where it's been applied to oncology patients.
Right. Shantanu, I can't not ask about COVID because it's in everybody's minds. It's one of the greatest unexpected impacts things healthcare industry has had this year. So can you talk a little bit about COVID and how it has impacted AI and vice versa, how AI might have helped solving COVID problems? I'd love to hear your thoughts on that.
Sure. I mean, I can talk about COVID. It's such a broad topic. I can talk about it just from our perspective, from the small myopic vision of JVON and the work we've done. So we were told by some of our clients, there's a system in New York, COVID puts a lot of pressure on systems, as we all know. And one of the pressure that the systems had to deal with was the unfortunate decision of who to provide care and who to not provide care. They had to make those decisions just a few months back in New York. A lot of systems were dealing with that problem. And when you have those kind of situations, you're short on resources and you want to make that decision. That's a good place to try to apply machines where human brain, it's harder for human brain to do that. So we were able to quickly spin off and point our machine in the direction of these kind of patients, even though there wasn't that much historical data to learn from. But I think with the parallels of COVID with other similar kind of outbreaks, we were able to get something out of it. And one of the ways that it was applied was in triage of ventilators at one of the system in New York. Now, what this does, that's one example where these technologies could be used in those kind of situations. But I think broadly, what COVID does is it puts a lot of pressure. Pressure means now you have a desire to reduce the cost. Pressure also means you have a desire to optimize. If you have only 17 ventilators and you are anticipating 120 patients, you got to have a few patients not get the ventilator. There's just not practically possible that everybody gets one. So when you are short on resources, it puts pressure on leveraging intelligence beyond human mind. And I think as that happens, we've seen within some of our client base, we had seen certain processes changing, attempt and desire to become more efficient, which means a desire for automation as well as AI. Telehealth, we are all seeing there's a lot of progress that's happened on that front. Just we were kind of forced onto that. But even beyond telehealth, just on surgeries, can you do something in an outpatient setting so you reduce the risk of patient being inside overnight? Yes, people are considering those things. I think overall it's a terrible pandemic and it impacts us in negative ways, but overall from a healthcare standpoint, it's gonna put the right pressure of reducing the cost. And hospitals working at 1% margin, they cannot afford to financially even be sustainable, even sustain if they do not become more efficient.
Okay, I think we are almost at the end of time, but there's one more question that is probably my personal favorite, and probably also seeing in some of the questions being asked by the attendees, is the future, right? Can you talk a little bit, what can we get excited about in the next 5 years, 10 years on what AI can do, and what do you see from a solution and impact? What maybe 2 or 3 different areas where people can get excited about where AI is going to help us?
Yeah, I think the most important one is more preventative medicine, proactive and preventative medicine. We still don't have enough, and AI is perfectly suited to do that. As we are collecting more data, and as organizations are willing to share more and more data, the EHRs will come around as well. I don't want to comment on any of those, but yeah, I think they are one step. They can do a little bit more in sharing data. But as we get there, application of preventative medicine is going to curb most of the healthcare waste and preventable harm that patients have to go through today. That's one. Second is, I think on imaging. Now it kind of ties into preventative medicine a little bit, but specifically on imaging. It's a great use case for AI, just better assessment of within radiology, scans. And sometimes people have brain aneurysm kind of things, and they're just waiting in a queue for the scan to be looked at. And when it takes 1% and 2%, in 2-3 days, the person dies. And a lot of that could be done by AI much, much quicker, within seconds, and probably even more efficiently. We haven't done enough of that, but people are getting there. I'm starting to see more and more papers there. So that's second. I think on imaging, there's a major impact that could be done. It's a classic case for applying AI. There's a lot of data, and you could train models very well as well. And the third one is custom care pathways. I think while we can look at these kind of problems, but the thing to marry all this and close the loop is custom pathways. This one I'm very, very excited about. The machine today, we have everything in the machines to tell us this cancer patient should have the most optimal pathway for them is this, 3 weeks of this, and then 4 weeks of this, and then that, and then you change their medication, and depending on how they are reacting, how their vitals are, you can quickly change. So all of those things are humanly very hard to do. We follow protocols that were written 30 years back. They work for the most part, but we follow those protocols, and not every patient gets as much time and attention from an expert. But these care pathways, once we start to have an AI get into them, we can leverage all the intelligence of our clinicians and research and bring it back into an accessible way where in a matter of seconds, you know exactly how the pathway has to change or what pathway they need to be put on. Those are 3 areas I'm very excited. I think if those could be done, even partially, our healthcare costs in the country, as well as just outcomes of patients, would drastically be changed.
Okay, great. I think We are almost at the end of time. We've got another couple of minutes. One last question I'm going to squeak in here. What about technology and the ease of adoption and implementation of AI? Do you think that's going to become easier and easier, more standardized, so that AI is not something that even for technologists like me, it's kind of a esoteric sort of behind the curtain sort of thing? Whereas is it going to become, ubiquitous in ways to implement AI in day-to-day?
Very good question, Seth. So standardized is one part of the solution. I think the other part is validated. If we find solutions that are more validated, they will drive adoption. Adoption is very intertwined with quality of the solution. And particularly in this space, when nurses are looking at patients and flags, or even doctors are looking at what a machine is trying to say, their adoption is directly correlates with the quality of what you are producing. If it's helpful, if you're telling them something they don't know, if you're telling them the right answers, if you're telling them making it actionable, they will use it more and more. And that's why I think along with standardization, there's a lot of validation that needs to happen. To me, I think there are two things that we all as industry can probably do. If we find places where you could either improve patient outcome or reduce cost by being more proactive, number one. And number two, test in a controlled setting before taking a solution out in the market, because these are patients' lives you're dealing with. So I think if those two things are done, then adoption will come by itself. Belief will come for solutions. If you don't test enough, then belief will go away. And belief doesn't go away from a vendor, it goes away from the industry. Yeah. The clinicians think AI doesn't work. They don't think AI from XYZ vendor doesn't work. They say, AI doesn't work. And that's a disservice to the entire industry.
Yeah. Good point. Thanks a lot, Shantanu. I think we are almost at the end of time. I'm going to hand this off to Tracy. Thanks again, Shantanu, for attending, for everybody joined today. Very exciting. And we're very happy to get this kickstarted from Telliant's perspective.
Thank you for having me, Chris. Thank you for having me, Chris, and Seth and Tracy.
Yes.
Thank you, Shantanu. Hey, I just wanted to give you guys kind of an overview. We have some upcoming events that are very notable, as on the slide. The Digital Health Leadership Summit from TAG, which we are actually exhibiting. So please get your tickets. And then there's the TAG Digital Health Georgia Healthcare Innovation Challenge, which Javion is one of the finalists, which is really wonderful. And then we've got a few other things. Thank you for attending again. We're going to provide you with a recording of this conversation in an email and on our website in a few days. And look for an invitation to our next conversation, which will be in January. And we'll be sure to send that out. And please, if you would whitelist us in your emails so they don't fall into your junk folders, that would be great too. But thank you for everybody for coming.
Thanks a lot. Thanks, everyone. See you next time.
See you next time.